for a number of years now, which I think it has its advantages. Lots of familiar faces on the call today. I've made lots of connections over the year. For people who don't know, I am a community health nurse specialist by training. Have worked most of my career in behavioral health, but kind of bring that community health lens to the job. So,
yeah, and I'm so glad you do, because it helps make my life a little easier. So at MHA, folks, we believe in before stage 4 philosophy, which is really an emphasis on prevention, early intervention, early treatment, that recovery-based concept all the way through. And I will say Commissioner Morris has always been a big fan of that kind of attitude. So we'll get into more details on that and like how the department is actually meeting some before stage 4 standards shortly. But I really think that's important from our point of view, where we tend to think mental health is like, everybody has a brain, right? We all have mental health. We all need to manage it. So that's kind of what makes us different, for those of you who aren't familiar with us, than some of the other orgs that are on the call, actually. So we have some great orgs that are complementary to what we do, right? We all work together, which I think is wonderful. Commissioner, could you briefly outline kind of DBHDID and what its structure is? Because I do think people get lost in the alphabet soups and the just sheer massive goal that you have there. So the massive group.
Well, the Department for Behavioral Health, which is what I'll just refer to it for short while we're together this afternoon, is part of the Cabinet for Health and Family Services. And I think that's an important thing to know, because we sit in this cabinet along with Medicaid, with community-based services, with aging and independent living. So functions like guardianship and child welfare and benefits like SNAP. And there's a whole lot that this cabinet does. And so I'm able to have professional and develop personal relationships with my fellow commissioners in those departments, which really enhances, I think, our ability to collaborate and do some work together. We write grants together, that sort of thing, and to help move the work forward. The department itself is divided into 4 divisions. Of course, the largest one is our division of behavioral health, which includes mental health and substance use. We have a children's branch, we have an adult branch, we have a prevention branch. It's a pretty big department. And then there's also division. There's 3 other divisions, one for developmental and intellectual disabilities, one for administration and financial management, and then one for program integrity, which is where our risk management, performance improvement, constituent complaints, those kinds of things are interfacing with the legislative body. All that sits in the program integrity division. We also have a number of facilities across the state. We have the acute psychiatric hospitals. We have a couple of nursing facilities. We have the Kentucky Correctional Psychiatric Center. In LaGrange, we have intermediate care facilities for folks with developmental and intellectual disabilities, along with some specialty clinics for that population. We contract with all 14 community mental health centers for all of the outpatient side, and about 140 other contracts that we have. So we work with a whole lot of partners across the state, but collectively our facilities and the CMHCs make up the public behavioral health safety net. And I think that would be the one takeaway that's most important for me, for people to understand, is that's really how we function, is that safety net. We take care of populations and provide services that others don't.
Yeah, and it's still so important. And I think people don't realize how many pieces of that safety net are really crucial to make it all solid and whole, or at least as solid and whole as we can make it, right? So I'm sure there's some gaping spaces, but we're trying hard. So that's amazing. Thank you for kind of giving us that brief outline. I tend to get lost in DBHDID, so I'm sure other people do as well. Yeah, so I mentioned before stage 4 philosophy, that prevention intervention. I know that pretty much follows solidly under the behavioral health division, a little bit of child and adult, right? And then underneath of that, I was wondering if there are any programs or interesting things you wanted to highlight, kind of given that aspect and lens that MHA brings.
Yeah, and I do. I think you and I talked about this a little bit yesterday, how much that before stage 4 really resonates with me as a nurse. And I think on your website, it talks kind of that analogy with cancer, right? You wouldn't wait till you get to stage 4 before you do anything, right? So prevention and early intervention are so critical with behavioral health. And one thing, whenever I talk to legislators or to any of my colleagues, I always talk about how important it is that we focus on our school age and transition age youth. We really want to change the trajectories of life. So much of the conversations people want to have is about when you have people with serious and persistent mental illness and what are we going to do now? And those are important conversations because there's a lot that needs to be done. But if we don't give any of our time, attention, and dollars, quite frankly, to our kids and transition age youth, we're not really going to change the future. We're just kind of trying to pick up the pieces after the fact. So we do have several programs. There's the tailored program, which some of our CMHCs have, which are kind of drop-in centers for transition age youth. Just a host of services there. First episode psychosis is a really important program so that we just right away get people with the right kind of treatment and engaged so that it doesn't, and I think that's the one that really can change trajectories. Lots of school-based services. That's been very difficult during the pandemic. We work to be sure that our schools are trauma informed. We work closely with Kentucky Department of Education, have for a number of years. I serve on a wellness committee and a school safety committee. We talk a lot about trauma there. You know, we say here, if you're human, you need to know about trauma informed principles and how to apply them to the work you do, but also to your personal life. And then another thing we talk about, everybody's heard about ACEs. We now talk about PACEs. So positive and adverse childhood experiences, because what we're learning is that creating positive childhood experiences is perhaps even more important, because sometimes those adverse experiences are hard to avoid. Things like divorce, death of a parent. Those aren't always things that we can change, but trying to create positive childhood experiences is important. So that's a lot of the work that we're doing there. Obviously, that's not everything. We have, like I said, we have a whole branch dedicated to prevention, suicide prevention and substance abuse prevention and some other things. But those are the ones kind of specific to mental illness.
No, I think those are all important. And you're right. I just asked for highlights. So just be clear, folks.
That's right. That's right. We'd be here all day if we talked about everything.
Exactly. And thank you for mentioning the cancer analogy for before stage 4, because so often a lot of folks enter treatment for the first time either by force, through a forced hospitalization, or in a jail program or a situation where we consider it stage 4 is when it's hit that really severe and it's probably a lack of will to go get treatment situation. So, anything before that is a place where we can intervene and improve recovery chances. So that is a big part of what we do. And I know it's what you guys do. So it's good to highlight some of those wonderful programs that have been started really since you've been on board, most of them. So it's been great to see that. I think actually this might be a place where we talk about 988, because that's really also like prevention and safety net, right? We've had that conversation a little bit. I would be remiss if I didn't talk about 988, because I am the co-chair of the funding coalition for 988. So folks who are not familiar, 988 is going to take the place of the National Suicide Prevention Lifeline. The Trump administration, the only unanimous piece of legislation during that entire time was to support this transition to 988. So instead of calling 1-800-273-8255, you just dial 988. And our goal here in Kentucky is to create a no wrong door solution with that. I hope that's what the commissioner agrees to. She's nodding. So yes. We want to create a no wrong door answer, right? So if someone is having a mental health issue of any kind, whether it's crisis level or, you don't know how to go, you don't know if it's a crisis or not, those are great things to call a crisis line for. So hopefully Kentuckians will be able to pick up the phone, call 988 and get help really in their region. We're supporting our model right now. The National Suicide Prevention Lifeline is answered at each of our community mental health centers. I think one of them rolls into another neighboring one, but they're all really local. So, and as we know, Kentucky is very different, right? Across the state, different areas of Kentucky have different resources. We have different cultures. We have different accents. So being able to be in that section is really helpful. I think it makes people feel at home to have someone who talks like them on the line, who knows some of the things they know. It gives us a relationship building piece to move from that. I don't think we can quantify very well. But I think that's a good start. So the department has gotten some funding to help with 988, and
Yes.
that's where I'm going to let the commissioner take over.
Yeah. So we, Beck Whipple, he's our state suicide prevention coordinator, and he's working with our planning grant, 988 planning grant. And then Beck and I are also involved in a national, it's called I think it's called the 988 Jam. It's we talk every couple of weeks with folks from across the nation. And I will say that I was actually asked to speak at NASHP. It's the National Association of State Mental Health Program Directors. So it's colleagues from across all the states and territories. We had our national conference last month, and I was asked to speak about what we're doing here in Kentucky, because so we're kind of seen as a leader with this planning, which we're pretty excited about. 988 is probably the biggest public health policy that's going to impact behavioral health since the expansion of Medicaid. So it's a really big deal. And one thing we want to look at is not just that number, right? And we've done some really good work at expanding our lifeline access and to have calls answered in state. We've seen a big uptick in that over the past couple of years. 988, we know, is going to increase our volume significantly. And that having no wrong door to get a call answered is great, but then what? So we know that our biggest challenge is building that robust crisis response team to have those services. And, we have all kinds of crisis services, but they don't necessarily work well for everybody. So we know we have issues that we have to continue to fix. Actually, I had my weekly meeting with the secretary today, and we talked a little bit about my budget request, because he said, this is a really big ask for 988. I said, yeah, it is, because we have to have all the infrastructure to go behind it. One thing we're really serious about is alternate response teams. I know there was a press release on the Dove project in Louisville. I think that was yesterday. I think it's on Facebook, where they talked about some grant that we're working on there. There's a couple other pilots, but we think that's going to be really important, is to look beyond kind of our traditional responses. We know we don't have the workforce to have, if we had endless amounts of money, we don't have the workforce right now to have teams of qualified mental health professionals that are going to be available throughout the Commonwealth. So who else is out there other than the police? One program we're really looking into right now is the idea of community paramedicine, which is using EMS and paramedics. There were a couple pilots, not specific to behavioral health, but here in Kentucky. The program is continuing in Fayette County, and we have some data on that. But we've just asked one of the paramedic instructors, he's an ER physician, he's going to join our statewide planning coalition to help us kind of work through that, explore, for instance, being able to bill Medicaid for the paramedics doing telemedicine. Right now, if they respond and they don't take somebody to an emergency room, they can't get paid. Well, we don't want them responding to behavioral health crisis, and only option is to take folks to an emergency room, because that kind of defeats the purpose. So yeah, there's a lot of work going on with that. And as I said, it's really exciting. To me, it's exciting in a different way than Medicaid expansion, which was phenomenal and continues to do a lot of good for a lot of people. But we really are optimistic this is going to help with access.
Yeah, I think that's really important to mention that, the funding piece that I'm advocating for is a fee, not a tax, y'all. Fee. Very important, because it only goes for what it's meant to go to, right? And we're looking to help boost that ability to have those facilities and the response teams and all of that. That's really important to do. And if we have a fee on cell phones that's less than $1 a line a month, I think we all recognize that we would love to do that and save lives. I think one of the big points with 988 is people tend to think mental health crisis only happens to people who are already quote unquote crazy. And we find that really they happen when life happens, right? So we find our suicide calls a lot of times are related to life events, like a job loss, a breakup.
And that's been the one silver lining of everything we've dealt with in COVID, is I think that society is getting finally that this mental health is, everyone has to attend to their mental health, and that there is no health without mental health. And so I think we're being heard in a different way right now than we have before, because it really is about everybody.
Yeah. And I think the more we look at that as a big picture, the better. And I love that the department is on board with that, not just treating the sick, right, but treating anyone who's got an issue, who may be just sick for a little while even, right? So that's really a lot of our folks with suicidal tendencies, in case you all didn't know, actually, it's a brief thing for them. It's a short period of time, and they're much better. We do have to watch them for a little while after they've been suicidal, but a year or two down the line, most folks really never go back to that state. And that's wonderful, as long as they're getting good treatment. So one of the many reasons they call 988, but also there's that other big system question, right? Where do I go? How do I help? I'm sure they're going to get some of those calls instead of them going to advocates like me, like they should, but I'm glad that the 988 line is there. So, and we'll be definitely working together to I think, improve the Commonwealth as a whole. And you're right, I'm excited about it. So in case you can't tell, y'all, keep smiling about it, because I love the idea. Let's see, and you mentioned COVID. And I told you we were probably going to get a question for COVID. And I actually really forgot on housekeeping at the beginning. Folks, if you have questions for the commissioner, she has said she will answer them. I will monitor the chat. If you can put them in the chat for us, and I will ask the ones that we can ask in the short time, because I know somebody might ask a question that's like 20 minutes. But feel free to throw your questions in. But I knew we would probably get a question about how COVID-19 and mental health have worked together. We are going to do a more in-depth webinar, like as soon as real data is more available for 2020 and half of 2021, because I feel like the 18-month view is a little stronger than just 1 year. But we will do a more in-depth, but I'd love to hear kind of what the cabinet has started, or what you think the sense is of COVID-19 and mental health. You kind of already mentioned that people are talking about it, which is wonderful. I mean, we've got more people on this event than usual. So I feel like we are opening doors that we didn't before, but I'd love to hear your perspective.
Yeah, so I mean, our department's been really involved throughout COVID, really right from the beginning, right? So you think first, this is a public health issue, but like I said, the behavioral health piece has been a part of the conversation from the very beginning. Our governor from the very beginning talked about how he would walk the dog, right? And do these other things to relieve his own stress. He was really transparent and open about it, which I think helped a lot. He asked us to develop a series of mental health videos, which I think you mentioned in some of our initial correspondence about today. So hopefully folks got to see those. Those were, back in the spring of 2020. We did some different mental health videos for school-age kids and one for preschool children and some other things. But we've done a whole lot of other work too. Mainly, we've been a resource for a number of people for secondary trauma and for resilience. Kind of for education, for outreach, for resources to help. We've had a lot of course, a lot of our own state facilities who've battled this, but also a lot of private entities. We've had a couple nursing homes that had some significant loss of residents. We've had, or staff, and we've done some outreach with them. Some of the work we've done has built on work we were doing before. We established a trauma roundtable, which had representatives from different departments here at the cabinet. That started under the previous administration and has really grown under this administration and in response to COVID. And we just all kind of come together and share ideas. We've identified champions in all the various departments. I don't know how many people know. I've got some really fantastic folks that work on my team. Miriam Silman, you might be known to several people. She's kind of my champion, my executive advisor on trauma and resilience. She works with both KDE and with us, and she facilitates that roundtable and is called on frequently by fellow departments and outside entities. One of the things she does is called Food for the Soul. She does that series for our cabinet employees. Talks about things like empathy distress, formerly known as kind of compassion fatigue, and how as this carries on and how difficult it can be to continue to be empathetic and compassionate, and how we struggle with that as healthcare providers. A lot of stuff on grief and loss. Then basically a lot of what she does is just trying to help departments that don't traditionally think about these things, like Medicaid, like income support, right? Like OIG's office, people that might not, don't really think about themselves the same way DCBS or public health might, to really learn the principles behind trauma-informed approach, what is secondary trauma and how that might be impacting their employees. Been a lot of focus on workforce and our own staff and how difficult the past 18 months have been for our teams. She's also worked directly with, as I said, with our facilities. But I want to brag on us for a little bit too, though, because our infection rates at our facilities has been comparatively low. We just had our risk management and mortality review of our facilities last week, and we're presented with some data. I think it was Dr. DeLeon. He's at University of Kentucky who kind of did the statistical analysis, but showed that the rate of COVID, not only infection, but deaths in our facilities were minimal, but they were far less than what was seen in the community. So we were very grateful for that. And we also just did a lot to offer vaccines. When patients were with us, we were able to offer the vaccine to them. And then on the DID side, we had a lot of success in getting vaccines to both residents and employees of the supported community living. So we were very proud of a lot of that work. But yeah, we've been very, very busy, and we make sure to answer any questions that come about behavioral health, but also to be proactive and make sure people are including that part of the conversation, part of their work. You are muted. You know.
That is weird.
There, you're back.
I am?
Yep.
Okay,
yeah, we
good.
heard that is weird.
That is really strange. Okay. My Zoom went completely blank in the place where the mute is. I've never had that happen before. So sorry, folks. That's a new IT thing, even for me. And I live on Zoom, I swear. Well, thanks for that analysis of COVID-19 and kind of a picture. I think that's really important. I wanted to make sure I go back to a question I should have asked before, because I think it's an important question, but it's more of a big picture question. Mm-hmm. So I was wondering if you have a mantra, strategic plan, mental map where you think DBHDID will go under your watch. So I'm just curious kind of what you think.
Well, I think the thing that I have been focused on during my time here has really been about protecting and enhancing that public behavioral health safety network. We want to be sure that there are, community-based programs, that those are accessible, that they're affordable. We want to continue to work on decreasing reliance on congregate settings and facilities, not just hospitals, but personal care homes and other settings. We want to be sure that if people want to live in the community, that that's an option that's available to them. As I said, we want to be sure there's a robust crisis services array, that there's alternate response teams. So all of that is really important. So it's about access, affordability. As I said, COVID's helped us with the kind of the message about stigma, and that there is no health without mental health, which I think is also a NAMI mantra. I think Kelly's off camera right now, but that's I think I have a t-shirt.
We've all adopted it. It's a Patrick Kennedy quote, as what I've learned. So we've all adopted that. Yep.
But I'll tell you something that I didn't come to the job with, but that has really become important, and I've already mentioned, that's that focus on our kids, on school age and then transition age youth, and that's become a growing priority. We're working much more closely with Department of Community-Based Services and Child Welfare on a number of issues. We work increasingly closely with the Education Department. Because it's just so important to really change trajectories, to really make that the legacy, right? The difference we're making. And there's also been a growing priority, really. Trauma and resilience has been a long time priority, but because of COVID, it just took a new level of emphasis, a higher priority, along with racial equity, and recognizing that racism is trauma, and that it's all wrapped in together, and really how important social justice is to our mission, and to be looking through things with that lens. And as I said, being here for 8 years is really been a luxury. The national average for a commissioner is 2 years. It used to be 18 months, so I guess there's been some more longevity but I think I rank, it just came out, I think I ranked number 10 for longevity out of all states and territories. So it's rare. And I feel very privileged to have been able to be here as long as I have. But because of that, I've been able to grow an extraordinary team to help us do those things. So I think a lot of people know Dr. Tina Robbins. She's been with the department forever, long before May. And she can do absolutely anything, but she's really good at implementation science. She's really good at kind of starting things and then setting them off, does a lot of stuff with kids. Miriam Stillman, who I already mentioned, who works in that kind of trauma resilient space, and then Rashad Abdur-Rahman, I think has been with you before, right, to talk and helps with that racial equity lens. So those are just three of a whole host of great folks that are there that help. We kind of revisit our goals and every year and kind of fine tune them. And so it's great to have a team of people kind of all pushing all the work that direction.
That's a good point. I'm glad that there's more than one of you, because we need more than one of you. So it's good, or at least more than one person with that mission, right? That's what I mean. So yeah, we can't clone Wendy, so we got to find other people to support, which is great. Yeah, and you mentioned the racism. Yes, I will put a link to the Rashad YouTube of what he did with us later. Apparently my screen has messed up completely. I can't even see the chat, so my apologies all. We will make this work. I will probably tap an audience member to read questions to me eventually if it doesn't come back. Technology, it's fun, right? So you mentioned the racial equity stuff, and I think that is important. I know that we're working on data as a kind of a baseline, right? We don't have a lot of data. So, and Rashad mentions that when he talks to us. So I think that's important for everyone to know. The more we look at what we're collecting as far as data is important.
She froze up.
Oh no.
Nope, I can hear you again.
Okay. We're back, sort of.
So did you want to talk about that piece, the racial equity piece?
Yeah, I was wondering if there's like any specific stuff that's going on right now. I know we talked about data before privately, so just kind of curious kind of what other measures might be going on too.
Well, the racial equity work, very similarly to the work I talked about with trauma and resilience, is something that this department is really taking a leadership role. Rashad is with our department, not accidentally, quite deliberately. He's someone who went to the secretary, and we were really glad to get to know him, and he's become a very important part of our team. So we made just huge strides, I think, in this area under his leadership. First, as I said, is recognizing that racism is a form of trauma and how that really connects to mental health and why it's important, and helping others to understand that. We have kind of change teams and champion in each one of the divisions, including AFM, Administration of Financial Management, that I mentioned earlier. They're specifically working on gathering some procurement data and making sure that we're giving opportunities to businesses owned by people of color, to we're contracting and working with folks, but trying to get some baseline data. Our division of behavioral health has worked with Dr. Nifley from U of L or Spalding?
He's at Spalding.
Spalding, okay. He's doing a whole series for practitioners on racial trauma and how to deal with that, specifically at our community mental health centers, but I think that's been opened up pretty broadly. That started a few months ago. The secretary has developed 4 pillars here at the cabinet, which he will tell you developed kind of organically, but one of those 4 pillars is equity. One of those is resilience. So this department is kind of responsible or taking the lead on 2 of those pillars. The other 2 are economic support and then health and wellness, but they all support kind of this umbrella idea that our mission here at the cabinet is to help people reach their full human potential. And so it's a privilege and a great responsibility to take the lead on those 2 of the 4 pillars, but we take that really seriously. And this is another example where the department, I was asked to present, the secretary recently had a retreat for the cabinet, and I was asked to present at that retreat on everything our department is doing with racial equity, to kind of challenge my peers to to do similar. And it was very well received. People had lots of questions. It was a focus of a couple other presentations as well. The other thing I think that's really exciting that Rashad is doing is he's put together some communities of practice. So that started, there was one for facilities and there was one for the community mental health centers. And now they're kind of working regionally. So the facilities and CMHCs are now together in one community practice so that we have the CMHCs, for instance, in the Western State Hospital region are now able to work with the hospital on some regional initiatives, which I think is going to have a much bigger impact on the community, not just on folks we serve. So we're trying to eke it out of just that kind of, it's not just for staff, not just for the people we serve, but to have more of a community impact.
I think that's important. Yeah. And at MHA National and at MHA Kentucky, we've both adopted the racism as a mental health issue aspect, which definitely is playing out at our state in ways that I don't think other states have embraced yet. So I love to highlight.
No, I don't think they have, but some have, but I don't think too many. But I'm grateful to be in a state that has.
Yeah. Yeah, we're doing really well. So if folks have questions, I can't see the chat sadly. So maybe go ahead and unmute if you have any questions you wanted to ask and we will.
Marcy, Marcy, this is Sheila Schuster. I had put a question in the chat for the commissioner. And I'm curious, Commissioner, about what preliminary results you're seeing from the first 2 years of the SAMHSA Tim's Law grant.
Yes, I told Marcy that question would come up.
And you know from me, because I worked on it for umpteen years.
Yeah, and I did testify at the SMI task force about Tim's Law recently, Sheila, and I don't know if you saw that, but there's I don't know if they record those or if
yeah, they're on YouTube. I thought it would be helpful for people on this.
Yeah. Oh no, I was going to answer you anyways. I was just making sure that you knew that.
The second question is, what funding opportunities do you see to take it statewide? Because that's the next step, obviously.
Yeah. So we're in the second year of a 4-year grant. It was a small grant. It was a total of $4 million for 4 years, so $1 million a year, which sounds like a lot of money, but I promise you that's not a lot of money. No. So it did get off to kind of a slow start because we were in the throes of COVID when we got the money, and it didn't really kick off until December of 2020. So about 6 months after we got the money. We do have a limited amount of data right now because we do some outcomes, some measures at the beginning, and then at 6 months after somebody's been in the program. So there's only 4 people that have been through those 6 months, and I don't have everything right in front of me, but the results for those 4 people was really good. It was very promising. Now this is a pilot and it's pretty restricted. The criteria is pretty, where all the referrals are coming from the hospital, and but so far only 1 referral didn't meet criteria. So the teams that are from the courts and the mental health centers and the hospital all kind of understand what the requirements of the law are. So everybody that's been referred has been appropriate. And what's I think really important is that the clients themselves have reported good outcomes. And so, there was, it's still there, right? This concern that forcing treatment is not going to have good outcomes, that if people are not kind of invested in their own treatment, that the outcomes won't be as good, that the black robe effect is only going to go so far. But these 4 folks also reported that they were doing better. So we expect to have additional data every 3 months. We do a report, so we'll certainly be keeping close eyes on that. As far as funding, I mean, we've requested funding for it every year since the law was passed, but there does seem to be maybe some new interest from the legislators. We got asset specific question, about funding. The governor's office is very interested in Tim's Law and also funding. So, my answer to both has been we need to get a little further in this pilot, but certainly before the legislative session, we'll be sure to, to share the updated data as that comes through. We would like to roll it out slowly though, so that we're sure that it's done well. So right now we're in the central state region and moving into the western state region. Hopefully we'll come with funding soon to move to the Eastern State region and then finally to the far Eastern Kentucky.
Thank you. I appreciate it.
Mhm.
Yeah, we were big proponents of Tim's Law, so I'm glad to see that. I do have the chat now, folks. So if you put something in the chat a little bit earlier, though, if you can repost it for me, that would help a lot. But I am in on my phone because that's what we do, right? Multiple devices if necessary. Technology, it's great.
Marcy, the earlier question was from Heather Robertson, and it's what's your vision consideration regarding tobacco treatment for people living with mental illnesses in Kentucky? We had a 2015 state summit back then, but not sure what traction has been gained since then.
Yeah, I'm pretty sure I was part of that summit because tobacco cessation was a big part of the work I did before I came to the cabinet. I ran the ARH Psychiatric Center in Hazard, which is one of the 4 state designated hospitals, and we took that hospital smoke-free a good while before I came to the cabinet. And one of the early things that happened after I came was we took all of our facilities smoke-free. So we do have a focus on that. It's also one of the Joint Commission standards. You have to be working towards that in the acute psychiatric centers. So we get all of our acute psychiatric centers report on that initiative. It's a hard time for folks to kind of focus on that because they're kind of in an acute exacerbation. But we've got in our prevention division, we have people specifically who work on smoking cessation along with other, with other substances. So yeah, it certainly hasn't risen to the when we did that 2015 summit, I really thought that it would get more traction than it did, but it's something we keep trying to revisit. So it's still on our radar and it still is part of the work we do.
I wonder, Commissioner, this is Sheila, if some more public education to the families, to the NAMI groups. When we worked years ago to try to increase the cigarette excise tax, we got a lot of pushback from the NAMI groups, quite frankly, from the families of folks with serious mental illness, saying that's one of the few pleasures that our family member has. And they saw it, as a positive in a sense for those family members. And we know that they have, such detrimental effects from the smoking. So I don't know that we've focused a lot of education on that issue, with our family members and so forth. Just a thought.
Well, it is kind of interesting. When we first went smoke-free, the experience I had at ARH, which I shared with my facilities when we went smoke-free here, and they all found the same thing, is we expected the big pushback to be from the people we serve, but it was in our facilities, the staff, right? Because it's easy to convince people to do things if you can. I'll let you have a cigarette if, right? And then also just because the staff didn't want to not get their smoke breaks too. So it's interesting. And that's not any kind of correlation with family motivation. Please don't misinterpret that. But the pushback doesn't always come from where you expect.
Mm-hmm. I think that's true of many programs. So we did a mini grant with the American Lung Association working on SPMI and tobacco use targeting public housing initiatives. So the folks that are in public housing right before it went smoke free. So explaining like that crossover and trying to help their employees understand that link, because there is quite a bit of a link. Our folks smoke more, right, than others, and they die earlier. So, right. So going smoke free was going to be a little bit of an adjustment for all of them. So they smoke more on average if they have SPMI than the average Kentuckian. So it was an interesting study to work from. All right. Any other questions, folks, that you wanted to ask? I know she's got so much knowledge and so much going on. Did we talk about the ARPA funding and kind of where some of that's going? Let's go ahead and talk about some of that, like
All right.
funding that's been flowing in. What are we doing with it?
So much money, so little time. Yeah, it's a lot. Well, I mean, I think, obviously we're trying the best we can to, to put infrastructure in place that's going to be sustainable. So one of the things is the 988 implementation, trying to use some of the money for that work. And then the CCBHCs, the Certified Community Behavioral Health Centers, we're trying to help our community mental health centers become certified clinics with a more of an emphasis on quality and outcome measures and some of those things. It's a kind of an arduous process. I know I saw Dee Werline from New Vista on here. So she was with us here at the cabinet and is now back leading New Vista, and they're one of the CMHCs that's working on that endeavor. Recovery supports is huge. So supported housing, support employment. Actually, what we do is support employment here in Kentucky is another thing that gets national attention. And I've been asked to talk about that at 2 or 3 different national venues. First episode psychosis, which I talked about before, those kinds of programs that can really help change the trajectory of lives. Supporting our regional prevention centers, which are part of our CMHC's primary prevention programs like Sources of Strength. So it's a lot. I pulled the list, and it's several pages long. I don't know if you can see this, like, I don't know. It's long. It's a lot. It's a lot of money, and it's we're trying to do a lot with it. But those are kind of the big buckets.
Yeah, it's a lot of money for a short-term limited time, and that's the hard part, right?
Yeah, and
so,
it's
yeah.
and it's going to a lot of different places, and there's some overlap, so it requires some coordination. But yeah, it takes up a lot of our time, but we're hoping that when we look back on this period of time, we're going to see that this is when behavioral health started to get the funding and attention that it needed. So
yeah, after being sorely underfunded for so long, right? And we're still got to fight that fight. So I don't know if Steve Shannon's on the call, but 22 years in running, right? We haven't had a raise. So for community mental health centers at the baseline. So we're going to keep pushing for that funding information. And yeah, I wouldn't be a Sheila Schuster convert if I weren't asking about, supported housing, supported employment for SPMI. So we are working with DMS. That's not her area, folks. We're trying to get that covered though with a waiver. Love to see a waiver where Medicaid dollars can be used to help our folks with SPMI handle life a little better and maybe enjoy a lot more better, steadier recovery. So just plug something else we're working on. But again, that's not the commissioner necessarily. So but anyway, any other questions for her, you folks? You got a lot of great people, really involved folks on the call. So
may I ask a question?
Sure, Walter.
When did the definition of psychosis change from loss of contact reality to concluding the symptoms of psychosis or symptoms of mental illness?
I'm sorry, I
don't know about that change,
I
Walter.
don't either. Sorry.
Unfortunately, we don't know.
Well, there's been a change. When I was young, you could have symptoms of an illness without have a mental illness and not be considered psychotic. Now, in the first episode, psychosis, the definition includes the symptoms as well as the illness, the mental state. Which
I'm going to blame the DSM-5 for that. I'm just going to guess because the timing of it, as I'm looking it up, looks like it's probably around that same time. So I'm guessing some diagnostic criteria changed with the DSM-5 that happened. I'm guessing that's part of it, but I'm not sure, Walter. I'll have to do some more research on that for you.
Thank you.
It's a good question though. Psychosis is tricky. I don't know if you knew this, Commissioner, but we had a 61% increase in psychosis screenings over the last 2 years. People ages as young as 8 years old taking that test. So yeah, a lot of first episode folks getting caught up in that, which is good because they refer right to the department's project. So, but yeah, we've had a almost 250% increase in youth ages 8 to 14 reaching out to us for screening. So I'm really interested in all the work that the department's doing with those younger kids because we're seeing it, right? We're getting more people taking a screening means they're looking for mental health information, and thank goodness they're finding us a solid resource, right? So, but our screenings are all online. They're the actual tools for those of you who are not familiar with them who are on the call. They're actual clinical tools that you would use in your office. We turn them into a clickable and sometimes change the language a little bit to be more accessible for somebody at home, not in a clinical environment. But we tested them with lots of psychologists and professionals, psychiatrists, others checked it out too, ran them, and they're clinically valid. So they're just basically a screening test And our information links to DIY tools and to resources like the department's crisis lines, like me for help with their insurance and things like that. So they're not stuck on their own. And then there's a lot of DIY articles also related to like stinking thinking, how do we stop black and white thinking, and all that kind of stuff that a lot of people need and may not have depression, right? They may not have major depression, but they're living in a black and white, everything's right or wrong world right now because COVID did that to people. They're kind of learning new things. So I'm curious if there's anything with our screenings data that would be helpful to the department. So maybe we should talk about that privately.
Yeah, let's talk about that.
Because we're starting to finally get, thousands that are worth seeing. I think we got 20,000 last year and we're on our way to 28 this year. So lots of screenings happening in Kentucky. So those are just Kentucky screenings.
Commissioner, this is Sheila Schuster. I don't want to dominate, but if nobody else is going to ask a question,
I have one.
I'm hearing over and over again, and I think COVID has really brought this up. Two questions about workforce. One is, how do we get more people to get interested in any of the very many mental health professions? But maybe even a more important part of that is how do we get more young people of color to get involved? Because I'm hearing from the Black and Brown communities how difficult it is to see a therapist who doesn't look like them, may not be culturally sensitive or competent. I think we're all working on doing that for our providers. But I think there's a comfort level for folks when they come into a therapy room and see somebody that looks like they're going to understand that situation. And I really don't know what role, if any, DBHDID plays in that or in any of that.
Well, it's one of those things we've talked about for years, but Dr. Tina Robbins, who I mentioned earlier, she's my senior executive advisor, is starting to do a deep dive into that workforce development. And of course, Rashad is here to help inform us as to the second part of your question. I have a bi-weekly meeting every other Friday, and tomorrow morning is one of those mornings. I meet with all of my fellow commissioners from the Southern region, and every week we talk about workforce. And has anybody come up with any new ideas or new kind of strategies? And it's heartbreaking. I mean, I've on more than one of those meetings, a fellow commissioner has broken down because it's so strained. We're very strained here in Kentucky. Unfortunately, there are some other states that are even more strained than we are. It's very difficult. And from what I'm reading, the demand for qualified mental health professionals is going to really escalate in the next over the next few years. So it's really important. And, I think things like reimbursement, like what we're paying people and, their services being
especially
billable.
Medicaid, especially the Medicaid rates are really low.
But it's a new generation. Some of the things that were enticing to me 40, 30 years ago are not of interest to folks. It's like, that not only are some of the fast food places paying more than we can pay people who work right for us, they pay them every day instead of every other week, and they don't have to wait a month to get their first check. So some of what's driving the younger generation into these other fields is it's not even about the work itself, but about and they don't care necessarily about some of the benefits we cared about, right? So it's interesting, but no, those are super, super important questions, how we're going to get this interest. But I think we also, this has been a challenge I've had to a couple of my facilities too, is we need to keep rethinking about what is the mix of that workforce, right? Peer support specialists, family health navigators in the community. There's all kinds of things that we've seen that work really well. So I think if we stay too hyper focused on just, the professionally trained workforce, we're kind of missing the boat. So I think they need to think a little bit more about the mix and how we use people and what their role is. I think there's a lot of room for growth there.
Kelly looks like she has something to add. Thank you, Kelly.
Well, it kind of builds on what you're talking about, certainly, Sheila, and that is, with Rashad being there, which is such a wonderful gift to our state. and to your, department. I'm really concerned about the impact that community violence is having on our Black and Brown community, but it's so prevalent now that it's even, seeping into all stages of the community. Of everyone is afraid. So on top of the COVID pandemic, what we're seeing is this increased just angst in the community about safety. And about, baseline survival. Is it okay for me to go out and go downtown? When there's community functions, people are looking all around them, even if it's a football game. And so the trauma and resilience piece that we're searching for, I think we're going to have to start really, in a concrete way, addressing these community issues of violence as part of this underlying trauma that is only compounded by COVID and isolation and all of those other things. And I think the other thing I wanted to add was, I think when we're looking at workforce, we have to think about penetration before we think about maybe even hardcore professionalism. There has to be other levels of fingers and hands going out into the community that are recognizable and relatable and culturally competent, to be able to start to even negotiate the rest. So that was just, when that kid got killed at the bus stop in Louisville, I was just like, my mind was blown. I can't imagine being that parent or that community where you can't even send your kids to the bus stop.
Yeah. And I mean, and we all have a responsibility in that, right? I mean, that's
right.
Some of the early lessons from Rashad, for me personally, I would have told you my entire life, I've been not racist, but what I've learned is that is not enough. It takes action and intention to help solve the problem. Being not racist is being passive and actually exacerbates the problem. He's recommended several good books. I mean, one I'm reading right now is called How to Be an Anti-Racist, and it's pretty eye-opening. There's a lot of history lessons to be learned too. That's one of the things we did at our retreat recently. We learned a lot about some, national policy and laws that have helped bring us to
So how
where
are we going to impact this trauma violence continuum? What are we doing specifically on that? Because to me, that's as big a public health issue almost as COVID has been. I mean, every day in Lexington, there's murders. People are murdered every single day, and they're people of color.
Kelly, I think that's a great conversation for us advocates to have, because I think there's limitations to the commissioner based on what she has to do, because bureaucracy has its little
I understand that, but it also has to come from the top down as a priority.
Yeah.
So when
I do think some of the PACES work is definitely related to that.
Yes.
And I know that we're trying to address poverty as a concept in Kentucky is also important, because a lot of this violence happens in areas of poverty. And I think if we're not impacting those folks and keeping Medicaid expansion at a very baseline and getting people to use it and use it for mental health, right? Those are all big struggles. I know the prevention part of the DBHDID has been doing some work in that space, I think. So I'm really encouraged by having talked.
I am too. Just want it to help.
No, it's good. Thank you. It's a good question.
I have issues with the issues that poverty is related to violence. Violence that's picked up on is by poor people, and when rich people have their poverty violence, they are covered by legal cover.
That's true.
In other words, the judge, before he got to be judge, and his friend, another lawyer, used to fight in the parking lot in Pikeville for regularly on Saturday night. Nothing was done.
Interesting. That's a good point.
Yeah, we have a lot of equity issues.
Yes, we do.
As a society.
Yep. And we're trying to tackle them one by one, right? Or at least a little bit of each, maybe. It's probably a better way to statement. So, well, thank you so much, Commissioner, for trusting us with this, bearing with my IT problems. Sorry about that all. But thank you so much for being who you are and doing what you do and being open today. I really appreciate it. I know it was a a big trust leap. It is for me
Well,
always when I talk to people.
you.
So I
Thank you
appreciate you all.
thank you for inviting me. I appreciate
Thank
it.
you
And I
all for
appreciate
coming
the
out to
questions
meetings.
and the conversation. And
It's a great conversation. Thank you all. Everybody
Thank
have a good day. We're going to give you back a couple minutes of your life. I don't think anything mental health can happen in 3 minutes. So thank you all.
Thank you, Commissioner. Very helpful.
Yes, thank you very much. Appreciate it.
welcome.
All right.
Y'all
We
have a
will
good
see
day.
what this recording looks like. If it came through decent enough, we will send it out if we're allowed to. We'll check and see the quality. I'm a little concerned, y'all. So we'll try to do that if we can.
Thanks, Commissioner. Thanks, Marcy. Thanks, Sheila. Thanks, everyone, for all
Thank
you do
you
all
all.
the time.
Thank
All right.
you.
Bye-bye.
Bye-bye.
Bye.
Apparently I can't end the meeting, so my apologies all. You'll have to leave. This has been an adventure today. Oh, goodness. All right, there. Can I do it now? Nope.